Yes, thank you very much. Thanks, Arnelia. So welcome everyone to the JUNIPER Consortium's monthly seminar. And first of all, I'd like to say a massive thank you to the Isaac Newton Institute for hosting our series, for the team there for all their administrative support in organising them. So just to start, a very brief bit of housekeeping. So please ask questions using the Q&A button, which you should find at the bottom of your Zoom panel. And you can ask these at any point during the talks, but we will take all the questions right at the end of the two speakers at the end rather than in between. So we've had a bit of a break from our seminar series over the summer in August, but we are now back with our monthly series, and I'm delighted to welcome today's speakers, Dr. John Reid and Dr. Gwen Knight. So John Reid is a senior lecturer in biostatistics at the University of Lancaster, and he is one of the co-investigators on the JUNIPER consortium. His research interests lie in understanding transmission patterns and their relation to networks of interaction between hosts, and he's a member of SPI-M. So Gwen Knight is an associate professor at LSHTM, and her work prior to the pandemic focused on understanding the dynamics of antimicrobial resistance using mathematical models. And during the pandemic, she's been doing lots of different things, but including work on settings of transmission for SARS-CoV-2, which leads us in nicely to today's talk, as John and Gwen are going to be doing a double act and speaking about nosocomial infections in the UK during the first wave of the pandemic. So John is going to talk about the CO-CIN study, which estimated the extent of SARS-CoV-2 in UK hospitals during the first wave, and then Gwen's going to extend this to look at the potential for wider transmission into the community. So with that, John, I'd like to welcome both John and Gwen to today's talks. And with that, John, I'll pass over to you to kick us off with us.
Thanks very much. I'll attempt a share screen. Hang on. Okay. Is that working?
Yeah. That's great. Thanks, John.
Great. Okay, so part one. So nosocomial infections, they're infections that happen in a hospital setting between patients or between patients and staff or staff and patients. And, you know, they're really important to get on top of, to understand and get on top of, because, you know, the hospital patients are by definition a very vulnerable population. If they, you know, they're already in hospital for some reason, usually not good, and so if they get infected with something else, it's usually not a great thing. And so infection control is a key concern in hospitals, particularly when you have novel pathogens emerging. And we've seen this before with previous coronavirus outbreaks during SARS-1 and with MERS-CoV. Hospital outbreaks formed a large component of the transmission events that occurred for those emerging pathogens, and in particular, like for MERS, the South Korean outbreak was largely driven by transmission within hospitals. Okay, so if we think about all the way back to the start of last year, it feels like a lifetime ago now. Obviously, we had our first wave, wave one, and this is what the official hospital admissions looked like for that period. They only started recording them from about sort of late March. So, so we'd already gone into lockdown by the point of this, the first point in this data time series, and you can see hospital admissions continued to rise up to a very high level, and then decreased almost exponentially. And so overall, by the start of August 2020, officially, just over 132,000 patients have been admitted to UK hospitals with COVID-19. And there was multiple elements that may have enabled nosocomial within hospital infection to occur. You know, this was a new situation nobody experienced before, perhaps underappreciation of the airborne route of transmission, and in fact other routes of transmission that could have happened in hospital settings. Systematically, there was loads of changes happening in the NHS to prepare for the pandemic, lots of disruption, and also other things such as PPE, personal protective equipment shortages, changing guidance as to how to use those shortages, and also, you know, just perhaps the overwhelming burden of patients and care needs within hospitals. Okay, but I had a look through the media reportings, and the first report I can see in general public about hospital acquired infections, HAIs, happening was when somebody unfortunately died on the 4th of March, who must have caught COVID within hospital. Okay, and so from an early stage, it was clear that this could potentially be quite a problem. So the CO-CIN study, or more formally called the ISARIC 4C study, is essentially a protocol that was set up prior to the pandemic to characterize patients infected by a novel pathogen. This clinical characterization protocol set out, had all the ethics sorted out and the protocol sorted out, so that lots of information could be collected on the first patients as soon as a novel pathogen was recognized in the UK and indeed elsewhere. And up to earlier this week, currently that's CO-CIN study has just over 230,000 COVID patients in the UK enrolled into the study. Okay, up to the end of July, by the 1st of August 2020, last year, that's the sort of the period that I'm calling wave 1. We had 78,000 odd patients enrolled to the study, and of those, 72,000 had complete admission and symptom onset date records, which I'll show in a minute, of what we need to try and understand who might have got infected in hospital. Okay, so the ISARIC 4 study, if anyone wants access to the data, you can apply to get access to it from that website there, and recruitment is ongoing. You can see how it's played out over the second and currently if we call our current situation wave 3. But in wave 1, CO-CIN recruited about 2/3 of the patients in the UK. So it's probably probably one of the largest, if not the largest, COVID-19 patient study in the world. Okay. So how do we identify who might have been becoming infected in hospital? From a simple point of view, if once we account for the incubation period, if you were infected, if you were admitted before your infection date, then you were infected in hospital. And likewise, if you were infected, if your infection date was prior to your admission, then you were infected in the community. Okay, but there's a large amount of uncertainty regarding when individuals' infection dates were. Okay, and so we used an observed or a fitted incubation period distribution for COVID-19, following a log normal distribution published by Laura et al. And essentially we use this to impute the date of infection for each patient in a multiple imputation kind of way. And so this is only possible to determine if individuals were hospital acquired or community acquired infections if both of those date records are complete for the patient. So both on admission date and symptom onset date. But luckily, CO-CIN has been quite good at collecting these, so about 90% of the CO-CIN patients have both of these records complete. And so this uncertainty in the incubation period means that we're kind of uncertain as to anyone's individual status, but we can put a probability on it. Okay. So what we do is essentially, as I say, multiple imputation, and we're trying to estimate the proportion of hospital-acquired infections as a proportion of all the COVID patients within whatever time frame we're looking at. And luckily, I found a relatively new method that had been published last year by Lott and Reiter, which is estimating pooled Wilson binomial confidence intervals using this multiple imputation approach. Okay. And thankfully for me, they published their R code as well, so I didn't have to try and understand the maths. And so with that, I can calculate the proportion and, importantly, the correct confidence intervals of our estimated who was hospital acquired among the COVID-19 patient population. And so we look at this overall from the whole time period from February to July 2020, and also stratified by week of each patient's symptoms, and also stratified by the trust and the care type that that trust delivers. Okay, so overall, we found that between 11.1 and 11.6% of CO-CIN patients were infected after their admission to hospital. So that's the sort of indicative of the overall scale of the problem here. In a normal flu season, anything more, my clinician friends tell me that anything more than about 10%, they would start to be concerned of serious lapses in infection control. But given that this isn't flu, this is COVID, and we've got a very susceptible population, particularly at this time, it's I would argue 11% is still not acceptable. Okay, and you can see in the main figure there how this changed over time. So this is aligning everybody by their symptom onset, the week in which they had their symptom onset. So rather than relying on when they're admitted, because some of these individuals could have been in hospital for quite a while, I've anchored everybody by symptom onset. And you can see that as the patient population rises, the number of new patients coming into hospital rises and then declines. You can see that the proportion also rises and then continues to stay at a relatively high level, okay, kind of peaking in mid-May. And if you look at the smaller inset plot there, that's just a quick plot of estimated numbers of patients, both who are community acquired, the dark dots, and hospital acquired, the sort of orangey dots. And you can see they kind of pretty much track each other from the peak downwards. So it's not that sort of rise in the proportion of hospital acquired isn't necessarily because of a reduction of new patients coming into hospital. I'll probably skip over this, but we did look at the sensitivity to our incubation period distribution, and the bottom line is that it makes a little bit of a difference, but not too much of a difference. Okay, I can go back to that if anybody wants the gory details. Okay, and so the other thing we looked at was how much did trusts differ in this proportion of hospital-acquired infections. And the plot here shows, is plotting each trust against the number of patients that we've got recorded for that trust in the CO-CIN data. And it's on a log scale on the x-axis, and then the proportion across on the y-axis. And you can see there's a lot of variation. Okay, the overall average is the horizontal orange line with associated confidence intervals, and you can see for the acute or general hospitals, those sort of dealing with emergency clinical admissions, the dark dots there, we've got a real widespread. Some trusts did really well, even though considering they've got very large numbers of patients. Others with even relatively fewer patients are doing much worse. Okay, and the situation is much worse again in so-called residential community and acute or long-term mental health facilities. So these are not for emergency admissions for physical clinical needs, although you might have an emergency mental health admission. But these are individuals who are not particularly sick with anything else, but they are particularly vulnerable, and they're generally in smaller wards, smaller hospitals, smaller trusts, dealing with a variety of different long-term chronic conditions. And it kind of reflects the care home situation in the UK. We see a much higher proportion in those types of care setting than in the acute and general care setting. So in the sort of acute hospitals, we saw about an average of about 9.7% hospital-acquired infections, whereas in the residential community and mental health care hospitals, we saw sort of between 62% to 68% roughly proportions. It's slightly comparing apples with oranges in that you wouldn't normally expect a COVID patient to be admitted to one of those residential community or acute long-term mental health wards. And also, if you've got an individual who happens to have COVID but needs admission to one of those wards, it's not clear to me as a non-clinician where they would actually end up being admitted as well. Okay. So using this information from CO-CIN, we can try to estimate what the total number of patients infected in hospital in wave 1 was. So we had an extract from the SUS data, which is NHS Digital Secondary Use Services data, which has a record of the number of admissions of COVID patients by trust, but only for those who've completed their clinical journey and have died or been discharged. And this data was extracted for me on the 24th of August. And so we're using the CO-CIN estimate of the percentage hospital acquired per trust, and then essentially just calculating how many we think, what the total number of patients for each trust would be, and then adding them all together. I mean, accounting for the uncertainty as well in our multiple imputation method. So of 82,000, almost 82,500 patients admitted before the 1st of August, we estimate somewhere between 5,699 to 11,862 patients were infected during their stay in hospital. Now, it's important to note that 82,000 is quite a low number. That was the number in the SUS data that I got. The official records show that that figure should be much more like 132,000 admitted prior to 1st of August. So I can't account for that discrepancy, and probably leads to why I believe we've underestimated the scale of the problem. Okay, and just to bring you up to date, so looking at how this is, what's happened since then. So we had a large winter wave in December and January of hospital admissions, and then a more modest wave currently in this summer. And by fitting taking a slightly different approach to what we've seen before, fitting a sort of a generalized additive model, basically a negative binomial regression with an offset term and a penalized spline fitted to time, we can estimate how the proportion is changing over time for the UK. And that's the plot on the right there. That's the fitted spline. So you can see in the second wave, the proportion increased again and then decreased in the spring, and looks like it's increasing again at the moment. Okay, this does have a whole load of caveats with it. We're assuming there's no bias in how patients are enrolled. So, for instance, if those hospital-acquired patients are enrolled more quickly than community onset patients, then that might lead to a discrepancy. But fundamentally, we're still seeing hospital-acquired infections happening in UK hospitals, despite our better knowledge of the virus and despite the currently increasing levels of vaccination in the population. Okay, so just to start wrapping up, this is the limitations of this. This is a very simple analysis. This is not a transmission model, so it can only tell us so much. It can't tell us about what factors might be explaining the variation between trusts, or even where transmission is most happening. Is it between patients, or patients and staff, or staff and patients, etc. There's lots of potential for bias, particularly in how CO-CIN recruits individuals. The protocol doesn't have any specific recruitment sampling protocol. So it's not necessarily at random. It's at the whim of clinical staff who've got time and inclination to recruit people into the study. So that can undoubtedly play a part. We also don't account for length of stay in this analysis. So patients who have a very short stay in hospital could get infected while they're in hospital and be discharged before it's been diagnosed. And so they would never appear in the CO-CIN data. And Gwen's much more finessed and refined analysis will show how this makes a bit of a difference. And so because of that, and because of the other things I said earlier, I suspect that we're underestimating the scale of hospital-acquired infections in this analysis. So just to give you a bit of history now, so it was recognised that this hospital-acquired infection could be a big problem in the COVID pandemic in the UK early on. That was discussed in SAGE as early as the 10th of March. The CO-CIN ISARIC 4C investigators provide SAGE with preliminary analysis on hospital-acquired infections 1st of April onwards, and an early version of this analysis was presented to SPI-M and discussed at SAGE in the week of the 12th of April. So the people that knew, essentially the NHS was definitely informed in April that this was a problem, and I'll leave it there. Okay, so just to wrap up then, so one of the things I think this shows is the value of having a protocol in place ready to go when you have a new pandemic, rather than trying to scramble and get something in place when that happens. So having that in place for CO-CIN was invaluable in enabling near real-time assessment of nosocomial infection. You know, the protocol, when they designed it, they had no idea that it could be used or would be used for this, but it was really useful. And so it provided early indication of the scale of the nosocomial problem in wave 1. As SARS-CoV-2 is likely to persist in the coming years, likely to become an endemic seasonal virus, it's critical that we learn how to minimize the burden of hospital-acquired infection for it, in much the same way as we have for other viruses and pathogens. And so that variation, I think, in the proportion of hospital-acquired infections that we've seen between trusts really needs some further research to identify why that might be the case, and to identify and promote best practice, rather than trying to identify places that did a bad job. I think it'd be much more useful to identify places that did a good job and see if we can learn from that. Okay, so just to acknowledge money from these two grants. So the grant that Gwen's leading is the first one, and then the JUNIPER consortium has also supported this work. And then my fantastic collaborators there, and thankfully this finally became a public paper, research letter in the Lancet, which I encourage you all to go and read and correct my mistakes in this talk. And that's all I want to say. I'm going to hand over to Gwen and try to stop sharing if I can manage now. Okay, over to you, Gwen.
Yeah, thanks, John. See if I can share screen now. Can you see that? Oh, everybody's gone on.
Yeah, we can see that.
Yeah, thank you. Thanks, guys. Okay, thanks, John. Okay, so my name is Gwen Knight. As Kira introduced at the beginning, I'm based at the London School of Hygiene and Tropical Medicine, and I'm also Deputy Director of the AMR Centre at the London School. And that really reflects that my background and thinking before COVID was about the spread of drug-resistant pathogens, with a focus on one theme, which was focused on the spread of MRSA in hospital settings. And the group of people that I've put on the list here came together quite early on, as John said, a lifetime ago, the beginning of last year, to try and pull some of that expertise that we had on drug-resistant pathogens in hospitals into thinking about the spread of SARS-CoV-2. And yeah, we meet very well. We used to meet weekly and discuss this. So I'm really presenting something that came out of our thinking within this group analysis. And I'm going to talk about the missing ones. So as John hinted at, I'm going to be really thinking about those people, or trying to get a handle on the total number of hospital-associated infections by not just thinking about the identified data that we have, but also what we can infer from that, from the identified known cases with hospital-acquired infections about what else might be happening in terms of hospital-acquired infection. Because fundamentally, what is a hospital-acquired infection? We can't see transmission, right? We will never be able to do, or it's very unlikely. She says never, and I should never say never. It's very unlikely that we'll have such a rapid and frequent and sensitive screening method by which we could detect transmission events occurring. And so we need to always, when we're trying to work out what is a hospital-acquired infection, who has acquired their infection in a certain setting, we need to infer something from what we can see. And obviously with diseases, what we can see is symptoms. So we think about a hospital, for example, here we have, I'm going to show 3 example patients entering a hospital, becoming infected. If they get a little plus above them, that's a hospital-acquired infection, and then progress to symptoms like a red fever and a cough. So here for this patient, they entered the hospital, they become infected. A reminder, if you have questions, put them in the Q&A in the chat there. So if you enter hospital, you can become infected, but you can be discharged before you progress to symptom onset, or you become infected in the hospital setting, infected in the hospital setting and progress to symptom onset. And then the key thing here is that we were looking at hospital-acquired infections that were defined as whether their symptom onset occurred before or after this definition, this cutoff for defining a hospital-acquired infection. So, for example, this patient on the bottom here would be identified as a hospital-acquired infection, whereas the second patient, despite having symptom onset during their stay in hospital, would have those symptoms, the symptom onset date prior to the cutoff, so post-admission but prior to cutoff, and therefore we would define this patient as having a community-acquired infection. That's simplifying a bit of, obviously, a lot of what the clinician does, dependent on patient trajectories and risk factors and things like this, but that's fundamentally what we were doing here. And it was very much data dependent. So as I said, when we met to discuss how we could try and estimate how much hospital-acquired infection was going on, one of the things that we had to do was try and understand what data was available. And as John has so nicely described, the CO-CIN data set was really amazing in terms of the wealth of information that it contained. And importantly, that it included the symptom onset date and admission date. Because a lot of the other data, so for example, the SUS data, a lot of that is, or all of that is date of first positive test. And so that lacks a lot of the information that we need to understand basically the denominator, who is being tested and when are they being tested, in order for us to be able to say something about when someone might have been infected. And so in this analysis that I'm presenting here, we used the CO-CIN data and symptom onset as a definition for hospital acquired. However, if you do that, what you find is that you don't detect everyone. And so that's really the question. This is the question that I tried to answer with this analysis. For every one hospital-acquired infection identified, so every person that pops up in our data as a hospital-acquired infection, using the symptom onset after admission definition, how many unidentified infections were there? And to do that, if you look again back at that diagram, we basically had this data here from CO-CIN, so the number of identified hospital-acquired infections, by saying how many of them in the CO-CIN data set had a symptom onset a set number of days past admission. And then what we wanted to do was try to identify or work out who these non-identified hospital-acquired infections were. There's a lot of identified, misclassified. There's a lot of words that we had to get straight. But hopefully you can follow me here in that we had identified hospital-acquired cases and then non-identified. And then within the non-identified, we split them up into these 2 separate definitions. So the misclassified were those that were classified as community-acquired when actually they were hospital-acquired. And I think from discussions with John, these are the main ones, or the main way that the identified hospital cases are inflated in his analysis, to try and not have to be based on that hard cutoff for defining a hospital-acquired infection. And then the missed infections, so those people that are infected in hospital then discharged prior to symptoms. And so we really wanted to try and go from that time series data from the CO-CIN of the identified cases with hospital-acquired infections and map back and try and work out the misclassified and missed. And so the way that we did that was to say what proportion of hospital-acquired infections do we not identify. So we basically did a probabilistic analysis where we said, well, what's the probability that someone enters the hospital as infected and discharged? What's the probability that they enter the hospital, they're infected, and then their symptom onset is before a date? And what's the probability that they enter the hospital infected and symptom onset after the cutoff date? And combine those together to give us a denominator, and then we could work out which proportion fell into each of those misclassified or identified categories. And that's obviously dependent on the length of stay, and we got that data from the SUS data for each trust and for each week. And then it's also dependent on your cutoff, so this sort of sliding scale. And for the analysis I'm going to present here, we use the baseline of 7 days from admission, linked to the ECDC and also the PHE probable hospital-acquired infection definition. So when we did that, what we found was that on average, it was about 70% of infections that were not identified, that were missed or misclassified. This same output shown as a box plot over the weeks of this analysis, which were from January 2020 to the end of July 2020. And this is across all the trusts and all the weeks. And as John showed, a lot of differences, a lot of heterogeneity in trusts. And I should have also said that this is just based on acute trusts here. So we narrowed down the analysis to just think about acute trusts in England because we thought they had more similar characteristics than including the more potentially longer stay settings. And then what you can see here is the time series of this proportion identified. So here you've got the 3 different components that I just showed you. Here you've got the 5-day cutoff, an 8-day cutoff, and a 15-day cutoff. So this is 8 or more, 15 or more, 5 or more. You can see that the proportion missed doesn't change with these cutoffs because that's dependent purely on the length of stay. That's the red line at the top. And the other 2 are dependent on this changing cutoff across the 3 facets. And so that's why they change over time. You can see that the proportion identified, the blue line, drops when you have a later cutoff. You're missing more of the hospital-acquired infections. And so so the next step is to ask, what can we do with this? So what we've done now is to use this, or what we can do now is use this to inflate that time series of the number of identified hospital-acquired case numbers to give estimates of the total number of hospital-acquired infections. We can also then say, okay, what about those people that were infected in the hospital, then went home or were discharged and then had symptom onset and severe symptoms after discharge and then returned as a readmission case, and they should really be called a hospital-acquired infection, not a community-acquired infection. And then the key thing, again, to think about those missed infections. They become infected in the hospital, discharged into the community, and then they could potentially go on to cause onward transmission. We think that potentially a lot of those infected in the hospital that remain in the hospital for their whole period of their disease obviously are unlikely to contribute that much to ongoing community transmission, although we don't really know how many infected, the sort of who infects whom pathways, but I'll talk about that a bit at the end. But we were interested in those missed infections, how much might they contribute to the onward community transmission. I should say here that we were always just thinking about symptomatic infections because we were just looking at the symptom onset data in CO-CIN. And so we didn't think about asymptomatic infections, so it's definitely an underestimate, but the proportion of infections that are asymptomatic, I think, is still relatively unclear. And so these are the stages that we did to generate these estimates. I'll just walk you through these. So as John mentioned, CO-CIN is an enrolment-based system and enrolled about 60 to 80% of patients in different trusts at different time points. And so we use the SUS data, again, as a sort of baseline measure of all total number of COVID-19 cases that were hospitalized. And we use that to inflate CO-CIN to account for the enrollment differences. And then from that, we could inflate the number of hospital-acquired infections in CO-CIN up to an adjusted CO-CIN number. So again, a sort of time series, adding up all of our 126 acute trusts in England to give an adjusted time series of how many identified hospital-acquired cases there were. And then we could use our proportion identified to inflate that identified number of cases to try and work out the total number of infections, so accounting for the missed and misclassified. And then we did that assuming that it's a binomial distribution, with the number of trials being per week being the number of total infections, and this proportion identified being the probability that you identify them. So sort of a back calculation to work out how many infections there were, and to account for, obviously we could use that to account for uncertainty. So that gave us an estimate for the total number of hospital-acquired infections. And then the other thing that we wanted to do was to say, well, for every missed hospital-acquired infection, what was that patient's trajectory once they were discharged? Could they then be readmitted and incorrectly be called a community-acquired infection, when actually they'd acquired it from their previous visit? And so that's what's shown in this in panel D here. This is back calculating their time of infection and then their probability of returning as a readmission. And then finally, for each of the missed infections, we assumed that they could go on and cause infection in the community, and the number of infections within this 4-stage generation transmission chain. For each of those, we used our estimates from the epi forecast team to calculate the number of secondary cases that might have been occurred. And then from them, similarly to what the analysis in panel D, we looked at how many of them might actually return as a hospitalized case. So those are our 3 numbers that we tried to estimate. What did we find? What we found here is in black, all hospitalized cases, and then in blues, the number of community-acquired cases, and in orange is the adjustment to count for hospital-acquired infections. So not a very big impact on the number of cases there. And this is shown as a proportion of hospital admissions at each time point. You can see the vast majority of cases in hospitals are community-acquired, but a changing variation number, a changing number that were hospital acquired and shown in green, or misclassified shown in yellow, and in red is these linked cases, so those that were infected in the community but acquired from hospital infections of this 4-generation chain. This is showing it instead of as a time series, as a sort of total accumulation here. As John mentioned, there's lots of subtleties in terms of the number of SUS cases that were in your SUS download and the number of trusts included. So we were just looking at acute trusts in England, not the whole of the UK, and not all trusts. And so we ended up with a total of 79,000 as our base number of the number of COVID cases in hospitals over this time period. And what you can see here is in the blue circle here, the number of estimated hospital-acquired infections, and in green are the number of hospital-linked onwards infections, which then cause cases which appear again within the hospitalization numbers. I should say here, I'm just showing you the means, and we had a 95% range over 200 simulations, and those 200 simulations took in uncertainty from all of the different stages here. So we did bootstrapping of the length of stay, sampled from the natural history distributions, and also sampled from things like uncertainty in the proportion of patients that would be of infections that would become a hospitalized case. But I'm not showing you those in this bubble diagram here, but I will show you them in our percentages. So we think that in the data set that we have, about 15% of identified hospital community-associated community-acquired infection cases were actually hospital-acquired infections. So that's, if we add up these 2 that were linked to some kind of transmission from the hospital, C+F, and divide it by all those cases that at the moment are identified as community-acquired, when you just use a symptom onset of 7 days from admission. So that's sort of saying that we think 15% of those cases could potentially have been avoided if you prevented hospital-acquired infections. And then if you add up B plus C, so these are the hospital-acquired infections so we think about 20% of all identified hospitalized COVID-19 cases were hospital-acquired, and that's adding up those that have a symptom onset past your 7-day cutoff, those that have a symptom onset before that 7-day cutoff, but we think are actually hospital acquired, so there's sort of misclassification, and then those individuals that were missed and then were readmitted, so they were a hospital acquired infection, discharged into community and then returned again as a hospitalized case. So lots of limitations to the analysis. Big one is that, as I mentioned, we're just thinking about symptomatic cases. This analysis was all done at the England, sort of the aggregated level, so we pooled all of our trusts, but we did look at doing it at the individual trust level, but there was such a lot of variation, it was hard to, without identifying trusts with low case numbers, it was hard to really do this analysis at that level, but we did find similar percentages that were hospital acquired. We just had some differences in the contribution of the hospital linked cases, which is probably to do with the initial bigger proportion, as John mentioned, some of them had very high levels of hospital acquired infections. We obviously simplified natural history distributions, and I guess that rolls into the next bullet point where we thought about an average population, so we didn't account for hospital demography, the fact that many of these patients would be older, partly because many of the natural history distributions, we don't know enough to segregate it down to so much detail. And as John mentioned, we were using CO-CIN, so we were reliant on CO-CIN enrolment and symptom onset definitions and recording within that. But in terms of overall contribution to all infections, if we do a bit of back of the envelope calculation, if we think that less than 5% infections are hospitalised, and we think that within the hospital contributed about 20% of those hospitalised things, then patients, sorry, then it's likely that less than 1% of all infections in the UK or in England, sorry, are due to hospital transmission. And that's something that you could probably have done a bit ballparky before we did this analysis, with some uncertainty around that 20%. So what can we do about it? So the next stage for us was to think about trying to model interventions that have been shown to work in practice and try to use them to support or inform policy. And so we did a systematic review of interventions to prevent nosocomial transmission of SARS-CoV-2, and we didn't cover PPE as there are several living reviews. We found a lot of articles about nosocomial transmission, but only 7 matched our inclusion criteria of being a high quality randomized, a high quality control, a high quality trial to look at an intervention impact. They all looked at preventing infections in healthcare workers, not patients, and they were all relatively weak or biased, with only one trial assessing a non-prophylactic system, and those that did look at prophylaxis used ones which I would now say are either discredited or have weak evidence of action against SARS-CoV-2 infection. So we really found no good evidence and definitely no estimates to put into a model of the impact of different interventions to prevent the spread of SARS-CoV-2 in hospital settings. And so we really believe that there need to be trials of things that are likely to have an impact, such as ventilation or different cohorting or different frequency of screening methods. And there's many reasons why that evidence isn't out there. And it's likely that many of these things are being put in place, but it's just important to have evidence to support which ones to go forward, especially in resource limited settings. So what about wave 2? What's happening now? As John showed you, there's still hospital associated infection going on, still nosocomial transmission going on, but there's much more screening in place. So much more recommendations about screening on admission and then during the stay. But something I touched upon briefly at the beginning is all about data dependency and about understanding what's been done. And it was really hard for us to get information about what different trusts are doing in terms of testing and screening regimens. And that's still true now for understanding what happened autumn of last year into spring this year. So Ben Cooper is leading analysis now of SITREP data, trying to do the same thing to account for testing now to say how many patients acquired SARS-CoV-2 in hospital settings. And then also to try and look at the transmission chain, so who's the primary source, and then what the impact of interventions might be. And this is using generalized linear mixed models as well as an ordinary differential equation model to simulate intervention impact. And this should be up on medRxiv soon. So in conclusion, the analysis we did to try and account for those missed infections suggests that around 20% of hospital cases of COVID-19 acquired it in the hospital setting. And that was really based on the fact that we found that the majority of hospital-acquired infections we missed if you use symptom onset detection only. But overall hospital transmission is likely to contribute to less than 1% of all infections in England. So we think that screening on discharge or quarantine could reduce the impact of these missed cases, but we really found it difficult to find information on the levels of interventions or screening that was happening. As John sort of touched on a bit at the end, hospital-acquired infections are a minor contribution to England in terms of infections, but we're worried about the mortality, worried about who these patients are, and that hospital-acquired infections might have a bigger impact on deaths than we currently realise. So again, as John mentioned, I'd like to thank the UK.THE and NIHR for funding part of this project and the MRC for my fellowship. The manuscript is currently under submission and is with medRxiv, so it should be up soon. I'd like to thank the CMMID working group, Callum in particular, Isaric, and Colin and Mark at PHE, as well as this group of individuals. I was trying to think of a name for us, John. Are we the Hospital COVID-19 Working Group of Spire? Maybe.
We are now.
We are now, okay. But yeah, most of that is led by Julie Robotham. But yeah, thanks for giving me the opportunity to speak. That's my email address, and I guess John and I can take questions now, but I don't think any have come up on the Q&A, have they? No.
Not yet. No, great. Thank you guys both. And yeah, if anyone has any questions, oh, one has now popped up.
Oh, right, there we go.
So Ewan Coleman asks, is PCR test sensitivity an issue for estimating the number of hospital HCIACs, hospital infections, since the probability of testing positive depends on the time since exposure? Should this be taken into account when determining if exposure happened prior to admission versus after?
Yes, definitely, and that's what we're doing in the analysis of wave 2. So that's one of the, at the moment, the probability of detection just depends on the length of stay, basically, in the cutoff. But we've now worked into that frequency of testing and type of test, and exactly as you say, with that, the idea of a PCR will only go positive. Well, yeah, the sensitivity of the PCR exactly as was said in the question, much more eloquently than I can say in the answer. But yeah, that's definitely something that we're taking into account in this analysis of wave 2. To do exactly what I tried to do there, from the number of detected infections, to inflate that number of infections based on knowing the probability of being tested, and if you're tested, probability that you're positive based on the time from your time from infection.
Can I pick up on something that both of you touched upon in terms of the interventions to try and reduce hospital nosocomial transmission? And I just wondered, I mean, obviously it's quite difficult, that I guess there's a lack of evidence base because it is all sort of still evolving. But is there anything that can be learnt from studies of other infections? Because by looking at sort of hospital-acquired infections, it's like norovirus or other, interventions that have worked for other things. Is anyone, I don't know if that's been thought about, but if you could think about interventions by looking at other diseases.
I think so. In a general sense, yes. Things like better use of PPE is going to be applied to lots of different pathogens. I think where SARS-CoV-2 may be a little bit special is given that the particularly basically the airborne route, right, which may not be as much of a problem for other pathogens, particularly something like norovirus, which is probably more about surface contact. But SARS-CoV-2, if ventilation is going to play a much larger role, I think, certainly than we've had for other viruses. Although influenza, you could argue that's got to have a substantial airborne component as well.
Yeah, and I think that's probably one of the reasons why we didn't find any good intervention trials, was because lots has been learnt from other ones, and they're just being, IPC is being implemented. It was just interesting for us as modelers to not as modelers, as people interested in what we should actually do about it, to not have clear evidence of the sort of stepwise additive effect of if you do this, it's better than if you just do that. I think, you know, a lot of things are being done, but it's hard to see how each one contributes to control or might contribute to control in different ways. And I think that's fundamentally a problem with a lot of IPC, that it makes a lot of common sense that these things will be efficacious, and so they're done, but they're not necessarily evaluated in a stepwise way to give you exactly which one contributes the most. So yeah, ventilation is probably happening, but we're not measuring when and where it's happening. That's something that we really struggled to get, was knowledge of any IPC control specifically tied to time series data. I guess it's obviously happening at individual trust levels, that they're hopefully analysing that data, but we didn't have it at a national level to be able to say this trust is doing this, and look, its hospital-acquired infections are lower, and therefore that's an effective intervention. That was data that we tried to get for a long time and still don't have, right? Lots of discussions about that. And we had a question from Louise.
Yes.
I think that's definitely true, Louise, and it's something that we thought about in the Wave 2 analysis. But yeah, we have some information now on, actually, no, we don't have information on variants, do we, John? We're assuming that the variant distribution in the hospital is the same as in the community, but we haven't gone past March 2021 with the current analysis. So
yeah, I know the CO-CIN study has linked up with COG, so they are sequencing some of the patients, but I haven't gone into that maelstrom of study access and data access issues.
Great, thanks. So if there are any final questions, so Jumpy, okay, I'm going to allow you to talk, Jumpy, and you can ask your question. You should be able to talk. If you unmute yourself, Jumpy, you should be able to talk.
Yes, maybe, yes, you hear me now. No, it was more of a theoretical question on the start. I mean, this is a kind of back calculation problem that you have with these days between infection and symptoms. What technique did you use for back calculation? It sounded like you kind of moved back every patient by himself when you kind of tried to estimate when the infection date was. Or did you do something more refined in back calculation, some kind of smoothed back calculation? So it's more of a technical question on how this back calculation was performed from the start. Thanks.
Okay, thanks. So for my analysis, I was imputing it based on the incubation period distribution to impute an infection date. Gwen, who can correct me if I'm wrong, was using a mean incubation period and applying that to everybody.
I know, I did sample it from a distribution, but I did more at the individual level, yeah. So this is for each simulation, for each individual sampled from an incubation distribution. But yeah, it was just that jump out. It wasn't like we didn't do any smoothing, or I didn't. No.
Great. Well, if there's no more questions, I'd like to thank both speakers. I'll give you a virtual clap, seeing as no one else can. But thank you very much. That was a really, really interesting talk. And this talk has been recorded. So if you have any colleagues who'd like to watch it, it will be available on the Isaac Newton Institute website, and I will post it on our Twitter account if people want to watch it later. So thank you very much, everyone. And our next monthly seminar will be on the 11th of October. And thank you again, John and Gwen. Have a lovely day, everyone. Thank you.
Thanks. Bye.